So in January of 21, switched up to pharmacy benefit manager and off the top saved 30%. You know, we literally saved some of our employees and their spouses' lives. And it was just very meaningful to everybody that, you know, was a participant of the direct primary care.
Specifically for Kalos, we saw a decrease ER utilization by 36%. I just really don't understand the stigma around mental health. I mean, your brain is an organ just like anything else in your body, but you're paying the bills. You should have access to what you're paying for.
Welcome to Ethos.
The Business of Benefits is your no BS, no sales guide to real solutions.
No gimmicks, just the truth about how to take control, transform your benefits, and care for your most valuable asset, your people.
If you're tired of the same old sales pitch and you're ready to rethink your benefits, this podcast is for you. The truth is out there. Are you ready to hear it?
Hi, I'm Patrick Williams, co-founder of Fiduciary-driven. Employers today need more than just renewal strategies. They need a smarter approach to benefits. And that's why I recommend the Business of Benefits podcast. It's packed with actionable ideas, thoughtful discussions, and insights from some of the top experts in the industry. For the past 3 years, Fiduciary in a Box has supported Ethos Benefits by delivering the fiduciary operating system that empowers employers to organize, document, and manage their fiduciary responsibilities with clarity and confidence. If you're looking to build a better health plan, not just maintain one, start tuning in to the Business of Benefits podcast.
All right, welcome to today's episode with the Business of Benefits podcast. This episode is really exciting because we had an opportunity to speak at SHRM26, their annual conference. If you're not familiar, SHRM is the biggest stage for HR in the country. It's the room where the people setting benefit strategy for organizations of every size come to learn what's actually working, among many other HR topics. So it's a really cool event. I really recommend getting involved if you're in HR, it's applicable to you. So getting invited back to speak was amazing for our team and stand in front of that audience and talk about cost containment strategy, among other things. It was genuinely an honor for our team. So really exciting. And it's not something that we take lightly, not something I want to gloss over. So pretty exciting event. And here's what I want to make sure you understand before we get into this episode. After the session wrapped, we had HR leaders lining up to talk to us and ask questions. And so one person would say, we've got 10,000 employees. How will this actually work for a population of that size and vice versa? And maybe someone says, we only have 100 employees, and how would that work? And the answer, the honest answer is yes. It works in all situations. So the examples you're going to see today have a couple different employers of different sizes. And the results that we walk through on stage have really nothing to do with how big or small that organization is. The bigger the population, generally you have even bigger raw savings. And that's just a part of the math. So the strategy itself isn't a big company play or a small company play. It works because the cost containment levers work. And that's just all there is to it. So the real unlock here isn't a single tactic. It's stacking those strategies together, layered correctly over a multi-year plan instead of just trying to fix everything in one renewal cycle. So that's the mindset that we're bringing to today's episode, and I hope you enjoy.
Good afternoon, everybody. My name is Chelsea Ryckis, and I am your moderator for today's panel. So before we introduce the esteemed guest, I have a question for the audience. How many of you absolutely love your healthcare renewal and look forward to it with every fiber in your being? One person, all right. Two, thank you. That's our client. Thank you. No, I'm just kidding. How many of you have heard the following? A single-digit increase is actually a good year. Okay. How many of you have felt like you've been backed into a corner? You haven't even seen your renewal. You're trying to plan your open enrollment. Everybody's telling you something different. And then you have to make a last minute decision and you feel like you're choosing the least worst option again. Yeah, am I speaking your language here? Okay, how about this one? You don't get any claims data. Because you're too small. All right. Am I missing any of the big ones?
The claims are the claims,
Sorry, you had bad claims.
which means I'm sorry, this sucks. We can't do anything for you.
Yeah. Okay. So that's where we're starting, right? I think everybody in this room can probably agree that the state of healthcare, specifically employer-sponsored healthcare, is, how do I say this respectfully? Garbage. I don't know how else to say it. It's bad, right? I'm Canadian, by the way, so I have a little bit of a different perspective, but I'm here experiencing the American healthcare system with you and trying to do our best to improve it. But I know the seat that you sit in. So the goal today, I know you've heard a lot of things. You have trusted partners that you hear from constantly. You're probably doing your own research. My only ask is that you come to this with curiosity, because you're going to hear a lot of different perspectives, ideas, on how to actually get control of your health plan over multiple years to get out of that reactive renewal cycle and what that looks like. So hopefully you can approach this with some curiosity. The second thing I'd say, the other reason that we're here, besides just learning, is there is a real liability for plan sponsors in managing health plans. How many of you here today know that you are a fiduciary of your health plan? Nice. That's much better than when I asked this question last year, by the way, so that's great news. How many of you have a benefits committee to help you make selections for your, okay, good. How many of you feel like you have a process to make good decisions, govern your plan? Okay, awesome. That's what you're going to hear about today, is how do we govern our plan and make good decisions so that over multiple years, we have better financial outcomes and, more importantly, better health outcomes for the people that we serve. So with that, let's get into it. Donovan, do you want to introduce yourself?
Yeah, Donovan Ryckis, founder and CEO of Ethos Benefits. Our whole positioning, we were founded from securities, and being a fiduciary securities advisor, I would bet most people in the room have a fiduciary representing their 401k. Our idea from day one, way back when, 15 years ago, was why can't that exist on healthcare? There's more dollars going to it. There's more healthcare inflation than there is actual portfolio growth and performance. So we're kind of robbing employees from their future before they ever even get to save and put away. So that is what Ethos Benefits does, and we'll be talking a little bit about that positioning and how it works for plan sponsors.
Good afternoon, everybody. My name is Stephanie Porrino, and I actually have been working in human resources for 30 years. And over the past 10 years, I spent in healthcare strategy and cost containment, and I learned so much. And I actually worked for Hendry Marine Industries, probably as the former HR director. I was the HR director, and I left in May. But I was there throughout the whole transition, and I look forward to sharing that with all of you.
Hi, thanks for having me. My name is Jaimie Jarvis. I'm the HR director for a construction and trades company, family owned and operated here in Central Florida. I've been in HR my entire working career. I kind of fell into the HR role when I had a bad experience related to benefits when I lived over in New Hampshire, New England area, and said I feel like I can do better than that. So,
Well, we're so excited for both of you to share your stories and journeys with the crowd today. To level set, we'd like to do this before any panel discussions about case studies. Donovan's going to take us through a couple concepts around fundamentals so that everybody is on the exact same page about what we're talking about today.
Yeah, there's a lot of terminology and benefits. I hear a lot of it used incorrectly on both sides. Brokers, PPMs, plan sponsors repeating what they heard from other brokers. So I kind of wanted to get everybody on the same page and make sure we're all thinking about the process and what's going on in the same way. So I think everybody's probably heard the term fully funded, level funded, self-funded, right? What that actually means is kind of in the term, right? All this means is when is the company paying for claims, right? So fully funded, it's going to be the highest estimate of claims. You're going to pay those. You're going to have no data transparency or audit rights. Regardless of how the plan performed, you're not going to get any of that money back. And then you're going to see an increase next year. You're not going to be able to know or understand if it's justifiable or, correct. Level funded starts to give you a little bit of data transparency. You have your highest estimate of claims divided by 12 months. That's the level part, right? You're paying level premiums each month. If the plan performs, you can get 50% back or 100% back, depending on the plan. but the plan design is still going to be structured and controlled by the insurance carrier. So you're gaining some data transparency, some audit rights. You have the ability to get some of the surplus back, but still not the ability to make any decisions to improve things and move forward. So what we're going to be talking about is self-funded, but the point is the structure and what you can actually do. So the difference with level funded to self-funded is just we still have that highest estimate of claims. Instead of dividing it by 12 equal payments that the employer is paying, the employer is now paying those claims as they're incurred, right? So they can go up and down to the same max at the end of the year, just like a level funded or employee funded. So what we're actually looking to do with a self-funded plan is you yourself are looking to make better decisions on how that healthcare plan is operated. And these are the 4 moving parts in any of those structures in every healthcare plan, okay? So starting with the pharmacy benefit manager, I think everybody's heard of the problems and complications with PBMs. They're going to set all the prices for drugs for all your employees. The network is what really employees think about when they talk about their healthcare plan. On the employee front, it's a network of physicians that they can or cannot see. They now know their co-pays. But on the employer side, it's a more important function. It sets the reimbursement rate for anything that your employees do in a hospital, out of a hospital, out of primary, and out of specialist, right? So that comes into question when we go self-funded. Are those reimbursement rates good and fair for your company? The third-party administrator, more commonly referred to as the TPA, this is going to be who's sending employee ID cards, who's answering the phone, paying the physicians, kind of doing all those administrative functions. And then the last part, of course, is the stop-loss insurance. That's what's actually protecting the plan sponsor and kind of setting those max limits of liability that we talked about. So these are all 4 different functions, and a proper plan should be measuring and managing these separately instead of just looking at it 2 or 3 ways, which is how it's often done with benefits brokers, right? In this industry, we call them BUCAs. It's Blue Cross, United, Cigna, Aetna. So you have one of those, and then the benefits broker brings 1 or 2 others as a benchmark every year, and that's it, right? We did our job. It's a much more complicated process than that when you look at it as 4 moving parts, and you can really open up the competition and the plan design as you go.
Does that make sense to everybody? The 4 pieces of the health plan before we move on? No questions? Okay.
And this kind of just highlights how important this is. So this is a metric that we track for all of our groups to really kind of drive home how many invoices, because a claim is really an invoice coming into the healthcare plan. And I think plan sponsors underestimate how many are coming in and how much we need to have oversight in that data transparency and those audit rights, right? So on average, we see about 18 claims per insured employee per year. Now that sounds like a lot because you'll know plenty of people in your organizations that don't use their health care. Then there'll also be some with 2 kids and a spouse, and they use a little bit more. So it typically averages out to about 18. So for a company with 500 insured employees, we're talking about 9,000 invoices coming into the healthcare plan. And the question is, how is that process being measured and managed? And is it being done responsibly? Do we understand the costs of those? Not just categorized in a condition, the silly claim reports we see, spend this much in spine, spend this much in heart, right? Like that doesn't tell us a lot. We really need to get it down to the details to be able to benchmark this. So what we have now is there's really only 2 kinds of employers, right? There are the ones that renew. They kind of shop those same carriers, maybe 2, maybe 3. The traditional strategy is to transfer more of that risk to the employees by increasing their premiums, increasing those deductibles, putting them in a ever-tightening network or changing the network again. And they're never seeing or understanding those 9,000 invoices, right? And to the invoices, like that's probably the largest area of accounts payable in the entire business. And we're hoping that a broker and an insurance company is doing it in your best interest, while both of them will say they are not a fiduciary to you. And I think the other important thing is to kind of think of is the purpose of any system is what it does. So we can't say the purpose of your health insurance is to keep your costs low when it has failed to do so over 20 years, right? So we need to kind of rethink that process. So the other type of employer are going to be the ones that govern. They understand how the claim operates. They've made these decisions going into the planning year, like you're going to hear from Jaimie and Stephanie. And they're constantly kind of auditing that with their consultants and making changes, making adjustments to benefit their employees first, which then in turn benefits the spend within the healthcare plan.
There's something that I heard once, and it's stuck with me forever, which is, as a plan sponsor, if you look at the healthcare supply chain and how you're purchasing healthcare, every entity or vendor in that supply chain, in the traditional model, a broker, a carrier, a hospital, a pharmacy benefit manager, TPA, bank, whatever it is, traditionally, they make more money when you spend more money. That's a complete conflict of interest. That's a complete misalignment. So if you take anything from today, I hope that when you hear these stories about how they decided, I'm going to take control of that supply chain and I'm only going to work with vendors that win when I win. That is the biggest takeaway to truly transform your plan over multiple years.
Yeah, one last thing on that last slide. So, the 2026 Milliman Medical Index, it's a study that comes out every year, 7.2% increase from 2025. And we're going to look at that number, but it's $37,524 for a family of four on an employer-sponsored healthcare plan. And that breaks my brain that it's $40K just to have health insurance for a family of four before they do anything else.
Probably with a $5,000 deductible and a $10,000 out of pocket, right? Insane.
So throughout this process, when we're thinking about the four moving parts, we're thinking about all these claims or invoices that come into a healthcare plan. This is how we want to kind of operate and think about risk and what we can do to maintain it and maintain level premiums and some consistency. So there's only four things you can do with risk, period. So we can attempt to avoid some of that healthcare risk and claims. We can reduce it by lowering our claims costs and our reimbursement rates by making different plan decisions. There's a certain part of the risk that the company is going to retain. And then the last piece is the most expensive piece, which is transferring that risk to an insurance company. And one of the big inherent conflicts in how this industry is structured is, what does a broker do? A broker brokers a risk transfer, which is the most expensive function. That is their most direct route to compensation. There is no mode of compensation for them helping a plan sponsor avoid risk and reduce it. So inherently, they're going to do the behavior that incentivizes them the best and the quickest, which is get to the risk transfer. And the bigger the risk transfer, the bigger the compensation. Well, unfortunately.
It's the same way that you would incentivize your own employees, right? Bonus programs, things like that. So a lot of the times when you're looking at healthcare, it's follow the money and you don't find the incentive to find the behavior.
So we're going to be talking about a couple of different terms. So I think this is going to be the one people are going to have the most questions on, because both Kalos and Hendry have a network replacement. But this goes by three different things. So in this, we're replacing that network function, that PPO plan, that HMO plan, and going without it, which is mind-blowing sometimes when people first hear it. They think they need a network. And it goes by three different terms. So you might hear these, they all kind of mean the same thing. So network replacement, reference-based pricing, where basically instead of allowing the hospitals to make up this inflated price and give a 50-60% discount on the PPO, we're going to go from a reference point, which is Medicare. Most hospitals accept 50% or so of their patients through Medicare. We know what those reimbursement rates are. That's our reference, and then we'll work up from there instead of allowing them to pick this huge price. Say, isn't it great if we discounted it 50%, but you still have this huge gap? And that term is also commonly referred to as the repricer. Right? Because they're getting these claims in and they're repricing it into something that is customary and reasonable. And this is not some wild concept. 13 states have adopted this network replacement for their own healthcare plans. It's been going on for a long time, and we're going to hear about two examples of how it's worked out for plan sponsorship.
All right, Steph, why don't you lay the land a little bit on Hendry Marine, the workforce, and we'll get into your strategy.
Sure. So, like I said, I've been working in HR for 30 years, and I want to tell a quick little story about my first foray, if you will, in changing from the traditional healthcare landscape that we're all familiar with to sitting now on a stage talking with you about how wonderful these type of transitions are. So 10 years ago, I was working for a different company, and we were faced with an 18% increase with one of the large carriers. And I will say it was a privately owned company. Now, 18% any company is almost not sustainable. So some of my leadership, unbeknownst to me, even as the VP of HR, went to a benefit consortium and came back to me and said, you know, the 18% increase is not sustainable. We're going to look at something called reference-based pricing, and this is how it's going to work. Can anyone guess what I said to them? I said, there is absolutely no way. You guys are nuts, and it sounds too good to be true. But understanding, you know, there had to be a balance between, you know, because I'm a mama bear HR person, taking care of the employees, but also being fiscally responsible to the organization. I decided that I needed to learn. And the way that I learned the concept was we took an EOB from one of my employees, and we had it from the carrier. We already knew what the cost was going to be, ran it through what it would be through reference-based pricing, and the light bulb went on. And then I got mad. And then I realized how many years I had been trying, how do you continue to stand in front of your employees and say, you're going to pay more, but you're going to have a higher deductible and your plan design is shrinking. So that to me was my aha moment, and I really hope you all walk away with some of those aha moments from here. But now going into Hendry Marine Industries, like I said, I just left in May, but I was there for the whole transition. And we have 300 employees. It's a shipyard at the Port of Tampa. 90% of the employees are men, ages late 40s to early 50s. So we're in the Tampa Bay area. They are on one location, you know, which for access and whatnot is convenient. But we went self-funded with a non-traditional healthcare plan back in 2017 because after being fully funded with the large carrier, then moving to self-funded with the large carrier, again, not sustainable. So went to a reference-based pricing program with an independent pharmacy benefit manager and what have you. What was interesting is when I joined Hendry in December of 19, they were with the RBP company that we continued working with, but they had kept the PBM that was from one of the large carriers. So that was really interesting to me because having gone through a similar transition at my last company, I knew when I finally was able to take the reins, that change for the pharmacy benefit manager was the first thing I was going to do. So in January of 21, switched out to pharmacy benefit manager and off the top saved 30% of the spend. So again, it's not just what the company is going to save. Think about the impact to the employees. When the company is saving money, the employees are going to save money out of pocket. So we went and made that change, and we did a dependent care audit, which was huge because we were able to identify over 30 people that were on our plan, self-funded plan that did not belong because they were not qualified dependents of the IRS. We did telemedicine for everyone because at that time COVID was COVID, and it was recommended we do that because we wanted everyone to have continuity of care. So those were some really impactful changes, but all in all, one of the things that was important was making sure that we had claims data, and that is the key to being successful as a proper fiduciary managing these plans is when you have data, you have the ability to identify trends, their current trends, but then you can also do predictive modeling of what you anticipate could be happening within your covered employees and their dependents' lives.
Can I add something?
Sure.
Data is not one page from a carrier that tells you how much you paid and your 10 top drugs. Data, what Steph's talking about here and what Jamie's going to talk about is to the penny accounting of those claim invoices. So it's not what the carrier wants you to see, it's your actual data.
The other thing I was going to add from what you were talking about earlier is, when you're with a traditional carrier, like I was for many years, those claims are auto-adjudicated, which means that there's no one watching it. So it's basically like your company is writing a blank check every month because they have control over what's being spent. And really, the reality is it's your second or third largest line item. You should have that control, not the carrier. So this opportunity is to get that control and data into your hands. So in 2022, like I said, we swapped out the PBM. We added international pharmacy, which was interesting in itself because I was always skeptical what that meant. But when it's embedded into your PBM plan, you can also see significant savings to your plan spend, sourcing it internationally. Your employees also typically pay zero out of pocket for medications that they need to have continuity of care that maybe they couldn't afford before. So think about what that's telling your employees, how you're taking care of them. The other thing that we discovered in 21, and I'll go through this a little quicker, was, again, being data-driven, making data-driven decisions. We discovered that 15% of our employees only 15% of our employees were using the preventative wellness benefit. Now, mind you, they are late 40s, early 50s, 90% men. I'm looking at the men in the audience, right? I'm sorry, but, you don't go to the doctor until, you have, an arm falling off or something, but the point was that we knew we had to take action, and we did. So we knew we had to give them access to care. We were looking at a deductible because the truth is that you can't have such a high deductible that your employees become functionally uninsured, which means they can't afford the deductible to get care, so they avoid it, which then in turn causes those catastrophic claims that will continue impacting your plans. So what we did was we actually invested in an on-site primary care clinic for the employees. They started out at 1 day a week. The impact that had for the employees from a recruiting, retention standpoint, and again, continuity of care, giving them access was unbelievable. We literally saved some of our employees and their spouses' lives. And it was just very meaningful to everybody that, was a participant of the direct primary care. We also offer on-site dermatology. If you think about every type of care that your employees are having challenges getting to, whether it's, even primary care, because there's such a long wait to get in to see primary care, that's a foundation for someone's health and well-being. Employees really need to have that to know their own roadmap of what they need to take care of. Dermatology was another one. We had an on-site mobile dermatology clinic come and look at our employees. We invested in the preventative wellness exams for the employees because they're working outside. So if you think about the ROI, in the longer term, this is not a short-term investment. It all comes out in the end, longer-term strategy. So also we have an MSK vendor, which is musculoskeletal. So working with someone like that, because again, we were seeing the data in our claims that was driving quite a bit of the spend. So those are things that can be identified, and that's when you're taking control of the vendors that are going to work on your behalf. And so you have the ability to tell them what you expect from them and have KPIs to measure their outcomes. In 2025, I remember making a change to the healthcare plan design. I said, you know what? We had two plans, a base plan with a higher deductible, if you will. It was like $3,500, $4,000. The buy-up plan had a lower deductible, but one thing was really missing that we changed in 2026. Because to my point earlier, the deductible on the base plan, we weren't seeing enough activity in primary care or any of those other type of care situations. So in 2026, we actually added co-payments into the plan for doctors, pharmacy, all the things that your employees need access to take care of themselves. Those are the kind of decisions that are made that have that longer term impact. Some companies look at it as, oh, it's too expensive. If we give them access to care, our costs are going to go up. Well, that's actually the opposite. Because when you don't give them access to care, they don't go, and that causes those catastrophic claims. So in the fall of 25, and this is the second time I had what's called the broker breakup. Anybody through that? Have you gone through that? Yeah. So it's not fun, but the truth was that the insurance broker we were working with was really, not meeting the needs, not meeting the KPIs that we were expecting. And I had met Chelsea and Donovan a couple of years ago and had been speaking to them and admiring what they're doing. And, we brought them in to be our advisor. And in the few months that I worked with them, I learned so much about even being a better fiduciary of the healthcare plan than I even knew before. And just having the support that they need and the fiduciary infrastructure was really, really helpful. But really, it's something that you look at all this and go, wow, you guys did so much. Well, you look at it, it's over a span of time.
Exactly.
You just have to take the first step.
So this is a great example. This is 8 years of strategy that Stephanie just walked us through, right? And she did one little step at a time based on claims data, based on being a good fiduciary. Now we're going to talk about Kalos, who their CEO was all in from day one, and there was no baby steps. They just hit the ground running. So we're going to totally switch gears.
Yeah, so
It was a lot of fun for Jaimie. You can imagine.
we are not located in one spot. We are multi-state. We have employees all over the state of Florida, in Georgia, Alabama. We've come in and out of different states with remote employees, so we really had to figure out a design that was not on location, right? That was going to work regionally, statewide, even nationally. So, you can go to the next slide. I remember I started at Kalos in 2021, and the owner came to me and he said, I'm so excited. You're going to own the benefit renewal, and I've done some research on self-funded, so I think that's what we should do. And good luck. Well, and I was like, okay. So ignorance is bliss, really, because I didn't know what I didn't know. But I went to our current, the broker that we had at the time, and was like, all right, I'm so excited. I've always worked at like super large companies, thousands and thousands of people, never been on this side of benefits renewal, and was excited to see my claims and the data, and they give you what they show you, right? Here's your top 10 claims. And I'm like, okay, well, these 3 people don't work here anymore. This person's irrelevant now. So but where's my real data? And they're like, no, this is the data. This is your overall spend, and here's some options for you. And it was 3 options that were they were not options. It was 37% increase is what they gave me. And we're a small family owned and operated. We can't subsidize the price to keep it affordable for our employees. We're a trades company. We're like blue collar workers. So I said, okay, well, we've got time, I want a self-funded option. We're not doing any of this. I want a self-funded. What does that mean? What can we do? And he just said, you're not ready for it. You can't handle it. It's a bad idea. There's balance bills. It's not going to be an option. And so he refused to present me with that. And then I went and we found other options. But we changed everything in 2022. We changed our network. We changed our TPA, our pharmacy, our stop loss. What we did was we had 2 plans with a big one of the bukas. We had 2 plans. We took our 2 plans and said, we want these exact plans. We want these exact plan designs in a self-funded setup. So then we started shopping around and realizing I needed a win. I needed something that I could go to my employees and be like, okay, look, this is going to be complicated. It's going to be confusing, but the plan designs are exactly the same. So everything that you were responsible for last year is going to be the same thing that you're responsible for this year, except no more copays. We're going to remove copays for primary care. So if you're sick or if you need to get preventative, you can still go to the doctor and you don't have to pay anything. So it's going to be fine. It's going to be great. It's going to be so good. And we're not going to raise prices. We're going to keep your premiums the same. And then that was looking back, I should have treated it more with a traditional change management plan, right? More of a plan instead of we got this. We can do it. But we figured it all out. We did it mid-year. for multiple reasons, and a few of them were because we needed to start saving money because we were forced into a renewal that was just, not sustainable. We had the capture of our employees. We were just coming out of our busy season. We knew that they were attentive, they were responsive. We could gather the information. Clearly, our CEO and owners were on board. So we did it, and it was really hard. We had limited data, so we had a network. We had an open network, and I said, I couldn't get the data from my old broker, so I couldn't be proactive in adding doctors to the network and making sure there was continuity of care, right? So I was just like, give me your doctors. Who do you want to see? Let me have them. Like, we've got a process, we've got forms. Let's get this started. Let's go through it. Some things went fine, and otherwise it was just clunky, right? It was very clunky at the beginning. So in 2023, one of the biggest things that we did was added a care coach advocate. And going back, that's something that we should have done right from the get-go. So then we had a unbiased third party, somebody that helped build our plan, that was a care coach, that they don't have to come to HR and talk about their health and their concerns, right? They can come and talk to me. They can also go to this third party. And so with that was a huge deal. At the end of our first year, we actually ended with a very large surplus. So because it's my plan now and I control what's going on with it, I decided what to do with my surplus. Now the recommendation was save it because you might not have as good a year next year. And I was like, no, we're not going to do that. We're not going to listen to your advice, professionals. We're going to do whatever we want to do. So we took our money and we kept our premiums the same. So we didn't have to increase anything. And then we took the rest and we divided up by how many people were on how many employees were on our healthcare plan, and we gave them a bonus. And we wanted to say, look, we know that was hard. Stay with us. The second year is going to be easier. Here's a bonus. Thank you for participating. Keep us informed of all the issues, right? And let's move on. So then we started people keep talking, they keep speaking up, and we keep addressing, and then we keep moving on. So they wanted, the primary care thing, that's awesome, but I can never get in, right? So then we started looking at direct primary care options. What can we do? So we implemented that the following year, and then just really building a plan, like how do I get people to use the plan so that they have the best and quickest route to good healthcare, but also incentivize them to use the route that saves us the most money, is going to be the least cumbersome in terms of actual use of the plan. So we added an additional network for DPC, but the premiums were a little bit more expensive, right? Because we have to pay a monthly amount for people to participate in a DPC. But what we wanted to do was make sure that people use the DPC, right? We want them to go to direct primary care. So we significantly lowered the deductible. It was a $500 deductible, right? And so we had over 50% participate in the first year. And the majority of them just wanted the $500 deductible. They didn't care about the $2 a week increase because they wanted the $500 deductible. Great, that's perfect. That's what I want you to do, right? And then so just slowly following up with people. Are you interested in DPC? You haven't selected a doctor. Let me help you. How can I do that?
One of the really great things about DPC is if you don't know, it's same day doctor appointments for the entire family. You can do a lot of your blood work. You can get obviously your routine medications and things like that. So it's really that access piece that was the game changer. And specifically for Kalos, we saw it decrease ER utilization by 36%, which is huge for claims.
Yeah. The hardest part about going through this process was trying to explain it. Well, first trying to learn it and understand it and implement it, and then explain it to an employee population who really doesn't care. I mean, it's fascinating to me. And my mind is blown all the time. I'm like, what healthcare laws are what's helping me? This is what's going on. But explain it to them in a way that they understand why we're doing it and what they have to expect from the plan. So explaining DPC, it's like going to the doctors in the 1940s, right? Have a community doctor, you go there, you don't just get 6 minutes with them, you don't spend longer in the waiting room than you do in the office. You get there, you have 45 minutes. Our DPC is great. Our owner has 10 kids. One of the direct primary cares went to the house for the day and did all the appointments at their house. They're very much community doctors, right? get all your immunizations there. You can get blood work, lab work, all that good stuff. So, let's see.
Direct imaging, the direct contract for imaging is a good one too.
Yeah, so again, having full access to my data, seeing what people are doing, what people are utilizing, and what can we implement and change and make better. And the best thing about this is it's not like a one and done, right? Like you don't just have your plan renewal and then open enrollment and then you look at it again maybe in mid-year. It's something that you're always evaluating. I have bi-weekly calls. With one team, I have monthly calls with all my vendor partners, and we're actively like looking what's going on, what are the trends. Lab work was a huge one in claims. Like an x-ray can cost $4,000 someplace, and then $150 another place. It's like, well, it's the same, I don't get it. It's the same body parts, the same machines. So looking for direct contract for imaging. Again, zero out-of-pocket costs. You can still go anywhere you want to go and pay the copay, right? I'm not going to demand that you go one place or the other, but here's a free option if you want it. And lo and behold, everybody wanted it. But I also realized I was a little skeptical about that. So I'm like, oh man, I don't know if I just want to offer like free CAT scans. Think about people aren't just like waiting in line to go get free CAT scans.
Well, and you also you've got free imaging, you've got free specialty drugs, you've got free cancer treatments. You guys have free mental health. Jaimie removed all barrier access to mental health, inpatient, outpatient, unlimited visits, zero copay, zero cost. What that did to the claims, on average, general plan sponsors are going to pay $14 to $17 per member per month on mental health. Kalos removed every barrier possible, $6, significantly less and much better access.
Yeah, I did that from day one. I just really don't understand the stigma around mental health. I mean, your brain is an organ just like anything else in your body, and it should be able to receive the same care. So that was one that the one thing that my owner said from the get-go, this is silly. Again, we're blue collar, right? We're 80% male, we're 90% under 40. So it's like very young population. These guys are not going to go down to a therapist. Jaimie, you're crazy, but they do. Yeah, a lot. And they recommend it to each other, and they need it, right? We all need it.
Yes, exactly. So to wrap up this a little bit, we basically, Jaimie made different decisions every single year, and we're going to talk a little bit more about these now in the official panel discussion. So we're going to talk specifically stop loss and TPA decisions, network decisions, and pharmacy decisions, and you guys are now going to see the financial results of these specific decisions. If you remember, these are the 4 pieces of every single health plan. So Donovan, can you take us through stop loss and TPA?
Yeah, one of the biggest kind of things to open your mind about stop loss, again, going back to that renewal process where you see 2 to 3 carriers. If we're looking at that stop loss function separately, I'll usually go out to market for about 30 different carriers. So look at how much we just expanded the network and the access and the competition to the exact same product. And then to the TPA point, it's to allow them to make all these changes that they want, right? If we're operating on a carrier's infrastructure, they're going to say, no, you cannot give people free imaging because they're not going to change their prices. They're not going to create a new network, and they're not going to bias people to certain vendors within or certain carriers and positions in their network over the others. So this is stop loss and TPA for Hendry Marine. So they've been funded 2 years, $2.29 million cumulative, and then last year when we started, we got out of the Consortium. I'm sure you have a story or anecdote about that problem.
It's just, what Donovan said is, I always wondered when I was earlier on in my career, like having the control of what my plan would look like. Because I remember brokers back in the day or insurance advisors saying, well, here are your 3 options. And I felt like I was picking the best of the worst because that was falling in our budget. And then now looking back, I felt like I was doing my employees back then a disservice. I just didn't know what I didn't know. But having access to all of the stop loss market really expanded my purview of it too, because we were in a consortium situation, which meant we were sharing the pool risk on the premiums for the stop loss. And getting out of that consortium, it was great for cash flow for the organization because we didn't have so much money tied up. So having that access and saving the money on the actual premium because we made this change was extremely impactful. So I always, say HR is contributing to the profitability of the organization, and these are ways that you continue to do that.
So to be clear, we came out of the captive consortium, not into it.
Right.
It does have a place, it's just not as often as I see it placed. It's fundamentally not a strategy. It goes back into that risk transfer. So it's stop loss and then another layer of risk transfer. It may be appropriate sometimes, but you have to have full access to data to understand that first.
So these here are some of the plans, because you have an independent TPA, like Donovan said, if you were with a large carrier, they're not going to allow you to profit or to get stop loss decrements on an on-site clinic. You're not going to be able to have these direct contracts for imaging. You're not going to be able to have direct contracts for surgery centers. And this is what impacts your costs. These are the levers you get to pull year by year. Now with Kalos, Donovan, did you want to talk on this one?
Yeah, we went straight into the network replacement. Jaimie covered that. She talked about the surplus we had first year, which the majority of it went directly back to the employees. And it was a significant, if you look at their cost share of the plan versus what they gave back to them, it was significant. It was the majority of what they paid into premiums the full year. So it was pretty awesome to see. And then, we made a TPA change here recently as well, because now we have 4 moving parts. So changing the TPA doesn't necessarily mean we're taking away the network, which is the interface for the employees. We can just change one function that is not operating optimally.
$0 cost sharing, which I didn't understand. I automatically assume that if you give something to an employee for $0, that means that it's going to cost the plan more, and that there's not a correlation between the two. So
because we have the direct contract to get better reimbursement rates on all the care, when you look at the portion that is the member share, it's so insignificant to the total invoice that's coming into the plan. Again, if it's going to work for the plan, it needs to first work for the employee. And that's what's going to lead them to choose that behavior.
So these are some wild numbers. Donovan, can you go through these?
These blew my mind. So we just shrunk it to 5 years for Hendry, 39,700 claims. So that's, again, 39,000 invoices. $50.4 million was billed. That's what the providers were asking for. But of course, they're on a reference-based pricing plan, so we're not allowing them to come up with a ridiculous price and then discount it. We're going the other way, right? So out of that $50.4 million, the plan only paid $11.4 million over those 5 years. So that's an average reduction of 77% and an average percentage of 123% of Medicare, which is astonishing. I don't know if everybody knows this. Obviously, this is a national conference, but here in Florida, we have an award, which is the highest average PPO rates in the country for reimbursements, which is 346% of Medicare. So that's the Florida average. Obviously, Stephanie and Hendry Marine is in Tampa, so they are in Florida. So 346 versus 123% without, forcing the employees into a network or dictating where they must go.
I want to come back to balance bills and do Kalos's financial results to make sure we have time for this.
Sure. So Kalos, we did 4 years. That's what we have so far since we went network replacement. We actually have claims data. So 23,763 claims, 23K billed, and 4.3 million paid. So 76.8% discount over billed. And I didn't put my percentage of Medicare, but it's close. It was close to that, to Stephanie.
Jaimie, you said something really interesting earlier that I'd love for you to share with the team. When you looked at this and compared it to prior renewals, the data, can you share that with everyone?
Yeah, so I'm not reviewing 23,000 claims, right, that come through, but someone is. And to me, what's going on here is that top row of data is what we're being sold to when we go to giving one of those traditional fully funded plans, right? And then the bottom row, that's what they're making. That's what they're paying. So that profit, the difference is their profit. And they're employer-sponsored healthcare plans, right? Like, we should be managing the spend. We should be managing it just like we project manage construction projects. It's a budget. It is not just, it is a budget to be managed, and it can be managed. So that, just seeing that on paper was like really eye-opening.
Astonishing, right?
Well, and think about it this way. For those of you that get the 1 or 2 pages of data and you see these numbers, you see, oh, wow, we had, 23.3 million in spend, and thank God my carrier has my back, right? Because they're showing you what was billed, not necessarily what was paid. So the more data you have, the better. All right, let's get into balanced bills. Take it away, Donovan.
Do you want to start with Hendry's first?
Yeah.
So balance bills, I think everybody's heard this. This is the boogeyman in the closet, and the reason why you should not make responsible healthcare decisions, according to some. Balance bills are an extremely low percent, but I found this really interesting because we weren't working with Hendry this whole time. So there's a couple of differences here, but the numbers are still really enlightening. So they had a 2.2% balance bill rate, which was a total balance bills of 352 over that 5 years, which I was blown away because I was like, I've never seen that many, and that seems wild. So $2.1 million in balance bills. But what's really telling is the settled amount for all those balance bills, under 15,000. So, I mean, when you look at it that way, balance bills are amazing. You should hope to get balance bills, because if you don't get them, the provider is satisfied with that ridiculous invoice they sent out that was paid. So if this process isn't in place, they essentially would have paid $2 million of inflated bills because they asked for it, right? And nobody was benchmarking it.
Can I make a quick comment on it?
Yes,
if you
please.
don't mind? So one of the things that I hear as an HR executive, and I do speak around the country, and I talk about reference-based pricing as being such a great tool to use as part of your healthcare plan strategy, that it's disruptive. And the truth is that what companies are doing in maintaining the same healthcare plans and doing the same thing again and again, that's more disruptive than making a wholesale change that has so much financial impact for not just the company, but the employees.
It's like choose your heart. Do you want to tell everybody cost continues to go up and we can't give you raises and sorry, you can't contribute to your 401k? Or do we do something a little bit different? How about Kalos though on the balance bill? Because think about it, they're kind of Kalos is actually larger, a couple hundred employees larger.
Yeah.
In the last 4 years, 2 balance bills compared to 300.
So 2 differences. For one, I'd like to say when a balance bill happens, the first thing that happens is the TPA sends that provider that sent the balance bill a letter saying, stop talking to the employee, you're talking to me now, right? And that's it. And none of those employees have ever been responsible for anything more than their SPC. That is not something a PPO would do. Balance bills exist on PPO. It's for anything out of network. They call them surprise bills. And when you get a surprise bill, there's no defense. Nobody's going to help you out. One of the things we changed for Hendry to stop that 352 balance bills is we gave them a wrap network, which is what Kalos has, which is why this number is drastically different. So that's something that was recently installed for Hendry Marine. We haven't seen a single balance bill since that's put in place.
And all that means is that you have a network for PCP and specialists.
Yes.
And reference-based pricing is only on the hospital claims, which are the big ticket items that blow plans out of the water anyway.
Yep. But for Kalos, because we have that wrap network in place, again, for primary and specialists, so that everyday stuff that the employees are doing, we make that as easy as possible. You're also going to save tens of dollars if you try to negotiate some of those. So, 2 balance bills. Can you back for us? 2 balance bills. They're requesting basically $18,500, and they're settling for $3,666 in almost 4 years. So 2.
We're going to end with this here so we can open it up for Q&A because I hope that this has been intriguing enough for some questions. Jaimie, I know that you should be proud of this, 0 employee premium increases in 4 years. That's pretty incredible. Right? I think that's pretty amazing given the fact what we're all kind of facing in the market. So if you had one piece of advice for the plan sponsors in the audience, the first thing that they could do, and granted they're not Kalos and they're not Hendry, but what would you say?
I would say ask the questions to your current broker or your current advisors, partners. ask them for your data and just gauge their response. If they give it to you, then you have something to look at. If they don't give it to you and you have to fight for it, they're probably not the right partner for you. And go from there. But you're paying the bills. You should have access to what you're paying for. It's just as simple as that, I think. I mean, that's what started my whole journey. And I think that's a great place to start.
Steph, would you add anything?
Yeah, I second everything Jaimie said, and the fact is that, you're a plan fiduciary, so you're responsible for, what happens with the plan spend, and it's important for everyone to really not be afraid to take a step. If you leave here, think about one thing you could do that would have an impact on your workforce immediately. And sometimes it's a matter of just evaluating your pharmacy benefit manager initially, which is the least disruptive, and then going from there. But it's a process.
So to sum up what these brilliant ladies did over the last 4 through 8 years, number one, they accessed their data. Number two, they governed their plan. They managed a real budget. They weren't victim. They really, really worked it. Layered over time, unless you were Kalos and you just decided to do all of it. But we did layer some other stuff in towards the end. And then sharing the wins. The employees need to feel the benefits of everything that you're doing. So first off, congratulations to both of you. You've done an absolutely incredible job. Audience, we're going to open it up now for Q&A. That QR code, by the way, is going to give you access to a documentary we produced called It's Not Personal, It's Just Healthcare. It shines a light on everything we talked about today. A second documentary we produced specifically about PBMs, ton of fraud, waste, and abuse there, lots of savings. 408B2, this is a broker compensation disclosure that you should have since 2021 on file. And then how do you start a fiduciary kind of governance process like some of you already have, like these ladies have. So scan that. But let's open it up now for Q&A. Yes?
I have several questions, but I'm curious to know primarily. Thanks. A couple of questions. When you were switching from a traditional plan, fully insured, to this, did you want an impact report? What did that look like? And also, what is your administrative burden with all of this? I'm very curious because you're owning it, you're designing your own plan, you're every little thing on there, and it's a constant. It seems like a constant, constantly. I get the savings piece, but what is, I get the effort, what the impact for, but it's a lot, it seems, from an administrative perspective. I'm curious.
I was going to say, when you work with the right insurance advisor, you're going to have a lot of support and guidance. And honestly, that was one of my main concerns 10 years ago when I learned about this. But it actually, because we had such a great support system built within the plan, like the care coordination and management, it takes more of the burden off of HR more than you think it will. So that was something that I was really happy with, because I was concerned it was going to put more work on us, and it was only 2 of us back in the day.
Would you add anything?
Yeah, same thing. I mean, I was a one HR person show when I started this, and I wouldn't have been able to do it by myself. I mean, I had partners that were there to give me the data and give me feedback based on the data that we have and recommendations for our trends and help with that. And I was just the one coming up with ideas and being told yes or no, and then same thing, stamping the final decision.
Yeah, you were directing the orchestra, and everybody else was doing it if you have the right vendors in place.
Yes.
I think there's a question here.
There's one down there and there's one behind you.
You can yell yours out in the meantime if you want.
Sure. So I guess I'm just wondering, how does one break free of Blue Cross, the Aetna, the Cigna of the world, while still maintaining access to care? I know there was mentioned these networks that are sort of built out, a la carte, if you will. It's like, how do you maintain that continuity of care? And forgive me, maybe it's a loaded question, but.
Yeah, it's a little bit of a loaded question. It really depends. Each carrier in each state, based on group size, will determine how much data you are owed, basically. So, if they'll say, oh, you're under 200 and you're in Florida, no, we're not giving you that. So that can certainly change the discussion. For Hendry and Kalos, we did network replacement, so they could go see anybody. Now, you can go see anybody, and then occasionally we'll have to deal with an unreasonable person. So we did have some administrative work to work them through that, because the admins at these doctors' offices, they're overburdened. It's a high turnover position. We're often having to work with the TPA to educate them through that. If you do have access to data, you can run a disruption report, so we can actually take every physician that anybody in a healthcare plan saw and run that against, and that's helpful. It's not always possible.
You can also take a graded approach, and instead of going reference-based pricing, we actually never recommend that a company do that first year, because we need to do a feasibility study. To your point, there's a lot of things that need to be done to prove that that's the right strategy for your population, but you can unbundle the plan and put in a Cigna network, an Aetna network. You could rent a network from a carrier, still get control over the other pieces, and then do that last.
The other thing I was going to add to what you were saying was that when we went from the transition from a BUCA to the self-funded, model that we talked about, we actually did a care coordination transition, or a transition of care. So we identified everyone that might have had issues or concerns with transitioning to a new type of plan and got those. They were the priority. Super important. Yeah.
So I think we probably have time for one more question.
Yep.
Okay, just out of curiosity, we talked earlier about how your brokers are in a traditional method. Obviously, the more you spend, the more they make.
Yep.
So in this benefit structure, how do you compensate your broker?
Per member per month for pricing.
Yeah.
It's a flat rate per employee.
Yeah, and really the performance and, it's KPIs, so, there's accountability with everybody involved. It's not just falling on the employer, it's everyone that's part of the healthcare ecosystem that the company is able to build.
The important piece is the control is with them. They determine our work. I mean, hopefully, we've never had an instance where anybody said, no, you don't deserve your fee, but it's not hidden from them. It's completely transparent, and it's a conversation every single year of this is the scope of work, and this is the associated fee. Did we earn it?
And the reality is that every 2 to 3 years under the CAA, advisors should be reevaluated, and there should be an RFP to make sure you're working with the right partner, and they're not just in it to make more commission or your premiums go up. So that's really important.